Alina Wong. I'm a gastroenterologist at Swedish Medical Center, specializing in inflammatory bowel disorders. I'll be talking about what is remission and how do we get you there. Specifically, I'm going to give an overview of the natural progression of inflammatory bowel disease. What happens when Crohn's disease and ulcerative colitis go untreated? I'm then going to talk about treatment goals and the use of treatment targets to achieve those goals. Together, this should give you an idea of a new paradigm in IBD management that personalizes treatment to each patient's unique needs and focuses on outcomes in decreasing long-term adverse events. Crohn's disease and ulcerative colitis are progressive inflammatory disorders of the GI tract that can result in serious complications and disability. Specifically, in Crohn's disease, the inflammation extends through the entire wall of the colon, from the mucosa to the serosa. Because it affects the full thickness of the GI lumen, it not only causes ulcers and inflammation, but can also result in long-term complications. You can see on the figure on the left that it can result in stenoses, or narrowing of the GI lumen, fistulas, connections between two GI lumens, such as the sigmoid colon and the ileum. You can see that on the bottom right of that picture, and also abscesses or infectious fluid collections. On the right side of the slide, you can see a histological image of the GI tract and a large ulcer, you can see that by all the purple in the middle of the slide, that causes transmural inflammation, which is distinct and specific to Crohn's disease. Crohn's disease is a chronic relapsing condition. The figure on the left shows the natural progression of Crohn's disease if left unchecked. You can see by the black line that it naturally cycles through bouts of inflammation. But as the red line and shading underneath shows, that later in disease, even in times without frank inflammation, when the black line goes to 0, there is ongoing cumulative bowel damage. Strictures, fistulas, cancer can result in surgery and loss of bowel function. This accumulates over time and causes worsening disability. This is best exemplified by the fact that approximately half of all patients with Crohn's disease require surgery within 10 years of diagnosis, and 1/3 require multiple surgeries. But if we can stop the inflammatory burden, as we can see in figure B on the right side, at diagnosis, and keep close tabs on it through tight control and monitoring, then perhaps we can prevent those complications and the subsequent bowel damage from occurring in the first place. Similar to patients with Crohn's disease, patients with ulcerative colitis can develop long-term complications as well. These include extension of disease from the rectum to the rest of the colon, pseudopolyps, gut dysmotility, anorectal dysfunction, colon cancer, hospitalizations, frequent steroid use, and surgery. Some studies suggest that around half of all patients with UC will require hospitalization at some point during their disease course, and 10 to 20% will require surgery during the first decade of diagnosis. This schematic on the right, which is from a paper on the natural history of ulcerative colitis, a systematic review, shows the percent of patients who experience a change in phenotype, as well as activity in colorectal cancer. You can see that extension of proctitis occurs in 30 to 50% of patients. That activity, a relapse within 10 years, occurs in 70 to 80%, that the 10-year risk of colectomy is anywhere from 8 to 11%, and that the rates of colon cancer are from 0.4 to 7.5%. Because of these possible complications, the goals of therapy in patients with ulcerative colitis have also evolved from just control of symptoms and improved quality of life, and instead towards mucosal healing, with prevention of disease progression to help avoid future bowel damage, surgery, and disability. In general, the goals of IBD management are the following. 1, to accurately diagnose disease. 2, improve symptoms, make you feel better, and improve your quality of life. 3, minimize steroid use, which, as many of you know, can cause significant side effects such as weight gain, fluid retention, decreased bone mineral density, muscle weakness, and neuropsychiatric effects, among many others. And avoid long-term complications, the strictures, fistulas, abscesses, hospitalizations, surgeries, and cancer. Because of all this, the goal is no longer to just improve symptoms, but instead cause disease healing and prevent the progression of disease in order to maximize quality of life. The recognition of the importance of minimizing disease activity at an early stage in inflammatory bowel disease led to the development of the treat-to-target management approach. In this approach, treatment targets are defined with the aim of improving outcomes and decreasing the risk of complications. The treat-to-target concept was originally developed by the Selecting Therapeutic Targets in Inflammatory Bowel Disease, STRIDE, committee in 2015. The purpose of treat-to-target is to identify a goal or target and then use that predetermined therapy monitoring to achieve that goal. So first, you conduct a baseline assessment where you evaluate a patient's risk of progression and develop a target. You target therapy to that risk, and then monitor your progress and adjust therapy as necessary. The end goal is early control of intestinal inflammation to prevent the complications associated with long-term inflammation. One of the biggest questions in IBD care is, what should the target be? Is it enough to just have clinical remission with improvement in abdominal pain, diarrhea, nausea, vomiting? Or do we need endoscopic remission so that we don't see any ulcers or redness on our endoscopy procedures? Or laboratory remission with improvement in CRP and fecal calprotectin? Or histologic remission that when we look under a microscope we don't see any evidence of inflammation? Let's first talk about clinical targets. Our clinical targets in Crohn's disease include resolution of abdominal pain and normalization of bowel movements. In ulcerative colitis, we look for cessation of rectal bleeding and also normalization of bowel movements. For many years, symptoms and clinical response guided IBD management. It was the main target of treatment in both practice and clinical trials, and today it still serves as a component of regulatory approval for our IBD therapies. But we quickly learned that targeting symptom control alone fails to prevent disease progression, as it does not always signal healing of the inflammatory process. In one of our most famous IBD trials, the SONIC trial that paved the way for the combination therapy of infliximab and azathioprine, half of patients in the trial who were in clinical remission had evidence of active inflammation based on endoscopy or CRP, and 20% of patients who were eligible for the trial based on increased symptoms did not actually have any endoscopic signs of inflammation. Similarly, this study looked at patients with small bowel Crohn's disease, so inflammation in the small bowel out of reach of standard colonoscopy, who were in clinical remission. They then underwent laboratory and imaging testing, and of these patients who were thought to be in clinical remission, 30% were found to have elevated CRP, 48% had elevated fecal calprotectin, a stool marker for inflammation, and 85% were found to have inflammation on capsule endoscopy. Together, these studies, as well as many others, show that it is difficult to evaluate evidence of inflammation based on symptoms alone. The reason behind this is that after many years, or not so many years of disease activity, your gut motility changes, surgery can cause changes, strictures can cause changes, and this can dramatically alter symptoms in both directions. So what other targets do we have? We can evaluate for remission with endoscopy, so EGD or colonoscopy. Using mucosal healing as a target, as visualized by endoscopy, allows us to distinguish clinical symptoms due to underlying inflammation from symptoms that are due to long-term damage. It also allows us to find and treat inflammation in the asymptomatic patient. Endoscopic remission implies resolution of mucosal friability or ulceration, and several endoscopic scores have been developed to assess disease activity in Crohn's disease, ulcerative colitis, and post-surgically. So you can see for Crohn's disease, we have the SCSCD and the Rutgers score, and for ulcerative colitis, we have the Mayo score. Here is an example of the Mayo score, probably the simplest of the scoring system. You can see normal in the top left, or a Mayo score of 0, and quite severely ulcerated in the bottom right, or a Mayo score of 3. We're able to use these scoring systems to monitor response to therapy over time in a more quantitative manner, and then use these scores to alter our therapy. There's accumulating evidence that mucosal healing, as based on endoscopy, leads to better long-term outcomes. The IBSEN study, a population-based prospective study, showed that mucosal healing after 1 year of treatment was predictive of reduced endoscopic disease activity at 5 years, lower steroid use, lower rates of surgery in Crohn's disease, and colectomy in UC. Here, on these two images, you can see the proportion of Crohn's disease patients not resected on the left, and proportion of UC patients not having a colectomy on the right. The patients who had endoscopic healing at the top were much less likely to undergo surgery than the patients who did not have endoscopic healing. Next, let's talk about biochemical targets. Inflammatory biomarkers are measurable substances that can quantify the level of inflammation. The first one, C-reactive protein, or CRP, is a blood test. It is an acute inflammatory protein that's produced by the liver in response to inflammation. Note, it's not necessarily specific to the gut and will increase with inflammation anywhere in the body and also with infection. The next frequently used biochemical target is fecal calprotectin. Fecal calprotectin is a stool test. It is a protein that is found in neutrophils, one of our body's inflammatory cells. The presence of fecal calprotectin in the stool is a marker of neutrophil migration to the GI tract, and hence GI tract inflammation. Fecal calprotectin and CRP have gained a lot of attention because of their non-invasive nature and decreased costs compared with endoscopy. At this point, they're not treatment targets on their own, but they can be used as adjuncts to monitor disease course. For example, persistent elevations in either fecal calprotectin or CRP warrant further workup with endoscopy. Fecal calprotectin greater than 250 has a positive predictive value of almost 100% to predict the presence of active disease in ulcerative colitis, and 78% for the presence of large ulcers in Crohn's disease. CRP level, on the other hand, is specific, but less sensitive for predicting endoscopic disease, as many patients have normal CRP levels despite documented inflammation. So it's useful in the patients who've had previously elevated CRP with their flares. But both are useful in monitoring disease activity. This was shown in the CALM trial. The CALM study evaluated the impact of treatment optimization on mucosal healing based on biomarkers in addition to or instead of symptoms. In this multicenter trial, 244 patients with moderate to severe Crohn's disease were randomized to a treat-to-target strategy based on treatment escalation to normalize fecal calprotectin and CRP, or to standard clinical symptomatic management. So basically, you had two arms. One arm had their medication therapy escalated based on just symptoms, and the other had their medication therapy escalated based on symptoms and biomarkers. They recruited adults aged 18 to 75 with moderate to severe Crohn's disease, which was based on clinical symptoms, endoscopy, and biochemical data. All eligible patients received a prednisone burst 9 weeks before randomization that was then tapered. The patients were then started at Humira at week -1 if they met failure criteria, and then they were reevaluated at weeks 12, 24, and 36. Those who met treatment failure criteria had their therapy escalated to weekly Humira or weekly Humira and azathioprine. In the diagram featured on the slide under B, you can see that the failure criteria differed between the clinical management group and the tight control group. The primary outcome of the study was mucosal healing, which was set as a CDIS score, another scoring system for Crohn's disease, less than 4, and no deep ulcers at 48 weeks. You can see here that the treat-to-target arm was associated with higher endoscopic remission at 1 year compared to therapy based on clinical target alone. You can see that the treat-to-target arm had met the primary endpoint in around 46% of patients compared to 30% in the clinical management alone. There was also fewer Crohn's disease-related hospitalizations, and endoscopic remission and combined endoscopic and clinical remission were associated with significantly decreased risk of adverse events such as new internal fistulas and abscesses, strictures, perianal disease, hospitalization, and surgery. This study, published in 2017, showed that tight control and monitoring led to rapid optimization of therapy and ultimately improved mucosal healing and decreased adverse events. The last possible treatment target is histological remission. This is really the next frontier. The thought is that histologic healing, or microscopic healing based on pathology with disappearance of inflammatory infiltrate and restoration of normal histological architecture, and getting patients in very deep remission, could result in better outcomes. This makes sense from a conceptual level, and there has been some data showing that microscopic inflammation in ulcerative colitis is associated with clinical relapse and increased risk of cancer. But data in Crohn's disease is scant, and there are a few prospective studies looking at this right now. What makes these studies difficult is a lack of consensus on how histologic healing should be defined, and if it's even achievable in large amount of patients. Also, histological healing can be difficult to assess in Crohn's disease because of its patchy distribution. You can see on the image on the screen there's biopsies taken from 2 patients in clinical and endoscopic remission, what we would call deep remission. But patient A still has residual architectural distortion, no inflammatory cells, but architectural distortion. Patient B has inflammatory infiltrate, but again is in clinical and endoscopic remission. At this point, we don't know what this means, and if getting this patient into histological remission is A, possible, and B, would actually alter his long-term outcomes. So what is remission? It is improving symptoms, but also working towards the end goal of mucosal healing in order to alter the course of the disease. The conventional approach that focused on control of symptoms in a step-up approach of medical therapy or via the use of surgical resection as the disease worsened or therapy failed to control symptoms is no longer sufficient to prevent long-term effects. Instead, remission involves assessing risk factors, setting a target, and then working towards that target with tight monitoring of symptoms, using labs, imaging, and endoscopy as adjuncts to work towards that treatment goal. Most importantly, treat to target is a collaborative approach between the physician and the patient. It is important to characterize each individual's disease process and adapt treatment goals to their disease phenotype. High-risk patients with extensive disease may need to be treated aggressively from the beginning. But in low-risk patients with more minor inflammatory burden, you have to weigh the risks and benefits. I hope this was helpful, and I look forward to seeing all of you on September 13th to answer any questions.